My name is Robert Shahverdyan. I'm the head of Vascular Access Center in Hamburg, Germany, in Asklepios Clinic Barmbe. Well, since the endovascular AV fistula or the percutaneous AV fistula was introduced, the main question was, is it better or is it as good as the surgical fistula that we have created since almost 60 years? And the rationale for this study was to compare the endovascular fistula to the closest to it possible surgical fistula. And since we are kind of a high volume center in Hamburg, Germany, and we're doing lots of both endovascular and surgical AV fistula creations, we were really interested to see how they compare with each other. The learning curve for the endovascular AV fistula was, for me, in my experience, very fast. There are two different techniques for endo-AVF creation, the ellipsis and the waveling systems. And after around 5 to 10 cases each, you get a learning curve, so you can do it very solid. It was a retrospective study with a prospectively collected data. We had 116 patients in the ellipsis group, 41 patients in the waveling group, and 90 patients in the surgical, so-called GRATS surgical fistula group. The eligibility was actually, we didn't exclude any patients because we wanted to have it as close as possible to the real world experience. So no patients with failed anastomosis creation with failed procedure for endovascular procedures were excluded. They were all included in the study. What we have seen is that the percutaneous endovascular AV fistula with ellipsis device had similarly high maturation rates as the surgical fistula. After 4 weeks, 80% maturation. From total patients, there were 88% patients for both ellipsis and surgical fistula. We have seen that the time from creation to cannulation for endovascular AV fistula with ellipsis system is much shorter than reported in the studies and shorter than the surgical group. We have seen that the procedure time for the ellipsis is significantly shorter than the rest of the groups, the surgical and the waveling group. Also, we have looked into the patency rates, and both or all three groups had reinterventions, and we have seen actually less intervention in the surgical group, but at the end, less ellipsis and the vascular fistula were abandoned or converted, so they were much easier to salvage. And the patency rates, which we have looked into after 1 and 2 years, were similarly high for ellipsis group and GRATS group at for example, assisted and secondary patency rates at about 85, 87%. As a conclusion, we could say, of course, there are drawbacks for the study because it was a retrospective single center study. We didn't have randomization. But at the end, it is the first study comparing those results. And we could show that the endovascular AV fistula creation with the ellipsis system is at least as good and in some points even better than the surgical fistula creation at the same location. And it also gives an option not only to create a valid, good AV fistula for patients, for dialysis patients, but it also preserves the options for the creation of the same surgical GRATS fistula for our patients, giving them a long-term possibility for a good dialysis success. The take-home messages are that you have to try the innovation in order to see what results are there. And after some struggling with a learning curve, you are familiar with the technique, and you can see and you can show and prove that this technique, this endovascular AV fistula technique, especially with the ellipsis system, has at least similarly good results as the surgical fistula. Well, the next steps would be, in a perfect situation, a randomized control trial comparing both systems with each other. In this case, we could exclude any bias. That is an expensive goal, and I hope one day I will be also part of this study. But at least for now, we can definitely know that the endovascular AV fistula is a good thing for the future. It will not replace the surgical fistula. It is not for every patient, but it will definitely be a major point in the next years.